Okay, welcome to tonight's lecture in the Global Public Health Lecture Series. I'm Peter Kern, the Director of the Global Health Minor, Professor of Political Science here. I'm filling in for Nancy Fitch, who is busy doing global health work around the world and can't be here at CEDA. So tonight we have a double header in store for you. First up is going to be Roger Furlan. I'm going to let them introduce their topics, and I'm going to introduce the speaker. So Roger is an ophthalmologist who practices at the Rocky Mountain Eye Center here in Missoula. He's been there for over 30 years. He specializes in glaucoma, cataract, and intraocular lens problems. He's also an adjunct professor of ophthalmology and visual sciences at the John A. Moran Eye Center, University of Utah. He and his wife Heidi traveled to sub-Saharan Africa and Central America with the Moran outreach teams, performing sight-restoring surgery and working with local physicians to improve care in the regions. Second up is Dr. Brian Sippy. Dr. Sippy received his undergraduate degree from the University of Kansas, attended medical and graduate schools at the University of Southern California in LA. His medical internship was at the University of Utah. Then he went to Emory University in Atlanta for a residency in ophthalmology and stayed on for fellowships in ocular pathology and vitreoretinal disease and surgery. He moved to Montana to join the multi-specialty ophthalmology group at the Rocky Mountain Eye Center. And he also holds affiliate positions at the University of Montana and the University of Washington in Seattle. He has served on the Montana Medical Association Board of Trustees and Executive Committee. He is past president of the Montana Academy of Ophthalmology and represents Montana as its sole counselor to the American Academy of Ophthalmology. He travels to DC every spring to advocate for Medicare patients and healthcare-related issues. His global health experience comes from participating as a volunteer faculty member for Orbis in China and Syria. So Roger and Brian have agreed to divide up their time, and Roger's going to go first. And since he's got a critical emergency that he has to leave for, he's going to take questions after his talk before Brian gives his presentation. So it's a little bit different than we've been used to, but I'm sure we can manage to handle that very smoothly. So, Roger, please.
Well, thank you, Dr. Kerr and Dr. Sippy, for inviting me. I'm sure happy to be part of this. I'm going to talk a little bit. So let me start by talking to me about global blindness, not only the scope of the problem, but some of the solutions that are out there. These are my credentials, and how I got tied into global outreach and eye care work is after I did my fellowship at the Moran Eye Center at the University of Utah. Over the last decade, they've basically developed and expanded an outreach division. And so I'm now on volunteer faculty. And so I've done most of my work, a majority of it in sub-Saharan Africa, but we've also been doing projects in Central America, and Moran as a whole goes to a lot more places than that. So I got a day job. I can't do this full time, but usually I'm going on 2 to 3 trips a year now. So, you know, in terms of the scope of the problem, global blindness is actually a big deal if you get outside the developing world. There's a lot of impact on the population, the economies of the regions, the humanitarian aspect. There's a lot of blindness in the world. It has great impacts both, socially and financially. The thing about the blindness in the third world is the big majority of it's either treatable or preventable. So it's a problem that you can really tackle and have a substantial impact on, and I'm going to show you some examples of how that works. And that'll be part of the talk, is what are possible solutions we can look at. So in developed countries like the United States, the level of blindness is approximately 3 per 1,000 in the population. They're what we in the eye business call posterior segment causes, which is primarily glaucoma and macular degeneration. These are diseases of aging. The causes are largely unknown, and they're mostly unavoidable and somewhat treatable. So we primarily deal with blindness in our older populations. In developing countries, the rate of blindness is about 10 times that rate. It's 3 in 100. The primary causes are what we call anterior segment causes, and these are eminently either treatable or preventable. Number one on the list is cataract, but there's also a bunch of preventable diseases out there that cause corneal blindness, that if you address them, you can prevent problems. This affects all age groups, so it's not restricted only to the elderly population. Causes are typically well known, and again, for most of them, there's either a treatment or a prevention that can be implemented. So when we talk, first thing we should ask is, what is blindness? So in our world, to pass an unrestricted driver's license, you need 20/40 or better vision. So that gives you a ballpark in our world. The bulk of people that come to us for cataract surgery are seeing with glasses between 20/30 and 20/60 vision, and that's when they're impaired enough in their life to get surgery. So in the developed world, the criteria are much looser than that. So if you're 20/60 or better, which is nothing that most of us would tolerate, that's normal in the developed world, in the developing world, meaning that you're considered functional, you're not even counted in the statistics. If you go from 20/60 to 2200 visual range, 2200 is the definition in our world of legally blind. So that's visually impaired. If you get a little lower down to the 2400 level, which is the big E on the chart, now you're badly impaired. And if you go below the ability to see the big E on the chart, then you're really functionally blind. You would have a hard time doing the activities of daily living, holding employment, and et cetera. So there's a sliding scale to some extent of what blind means. So we're going to look at some numbers in a minute, but what are the leading causes of blindness, again, in the developing world? And surprisingly, these aren't ranked in order of frequency necessarily, but just needing a pair of glasses, having a refractive error. There are lots of parts of the world that Dr. Sippy and I go to where you're not even going to get a pair of glasses. There's nobody, that's just not available. So you could either be very near or farsighted, and that alone puts you at a disadvantage. Cataract is the one that is most common. It accounts for more than half of all the blindness in the developing world. And it's the one, as I'm going to show you in a little while, that's most eminently treatable. Trachoma is a disease where you get repeated infections with a type of bacteria called chlamydia. And if you get enough infections, it scars the inside of your eyelid and your lashes roll in. And then every time you blink, it scratches your cornea and blinds you. So once you're blind from trachoma, very difficult to fix, and certainly not in the developing world where you need corneal tissue and eye banks and everything. But public health measures could eliminate the problem. Glaucoma is a disease that's a problem no matter where you live in the world. It's a difficult disease to treat here. It's certainly it's one of those chronic diseases that has no real cure. And currently, there's not a good regimen for treating glaucoma in the third world, and that needs to be worked on. Onchocerciasis is river blindness, you may know it as, and this is one of the few true success stories in what we're talking about. 2 decades ago, there were hundreds of thousands of cases of this a year, and I think in the last year it's under 150. And this is due to public health measures. So these things are, if you can eliminate the reservoir of the disease, you can essentially eliminate it. So it's one of the few real success stories that are out there. Xerophthalmia is just vitamin A deficiency. So in a developed world, you never run short of the critical vitamins, but if you live in a lot of these developing countries, and children can develop either visual impairment or blindness, and that can be cured with a vitamin A capsule every now and then, which is pennies. And then there's a lot of trauma out there. These people live in a rough-edged world. They get things stuck in their eye, bushes, and other things. So there's a lot of that, and just infections due to the hygiene. So that would be kind of the major hit list of the causes of blindness out there. What's the burden of blindness? Okay, so here's the ranking of the top 10 most burdensome health problems globally. And eye conditions, which now includes increasingly in the developing world diabetic retinopathy, is 6th on the list. So it's not a trivial source of trouble. It causes a lot of not only direct costs, but a lot of indirect costs. For every person that's blind in the third world, there's a second person that's a full-time caretaker, and you have 2 people that have to be fed and cared for that don't produce anything meaningful. So if you can cure 1 blind person in the third world, you actually free up 2 people that can become productive again in some fashion. So it's not a trivial source of trouble. This is roughly the distribution of blindness across the world. So you've got a lot of it in Asia, Western Pacific, and Africa. But one thing you need to know is that if you go blind in the third world, your life expectancy goes down dramatically. So your life expectancy is 1/3 from that point forward of your age-matched peers if you go blind, 67% reduction. And children that go blind in the third world typically have a lifespan of about 2 years. So going blind in the third world is often a death sentence. It might take a year or 2 or 3, but a lot of these people don't make it for very long. So again, there's a lot of morbidity associated with this. So here are some numbers, and these numbers are already about 10 years old, so they're probably they're probably underestimations. But if you look at only that severe category of blindness, 2400 or worse, totally non-functional, In 2005, that was close to 20 million people. If you expand that sphere just to the 2200 level, which is legally blind in this country, you now have tripled the number of people out there. So you're talking about 60 million people. And if you go down just to that 2060 level, which again, none of us would tolerate, if you go down to that level, it's 8 times. So you're approaching 200 million people that are blind or severely visually impaired. And they all have a net drag on their villages, on their cities, on their societies because they're not productive. And the problem's really only getting worse in most places because the population's not only growing, but the population's also aging. And these are, a lot of these diseases, cataract in particular, is certainly more of a disease of aging. So you're going to see the people over age 50 are predicted to double. These numbers were put together probably in about 2012. So again, depending on where you draw the line, you've got tens and potentially a few hundred million people that are blind. And again, here's the impact of blindness. So the blind person's not productive. The second person is also not productive. They both need to be fed and clothed and housed, but they're not producing anything. So when you get enough blind people in a region or in a village, the global effect of that, and if you certainly combine it with other problems they face like malaria and other problems, it's a big deal and it really dampens it down. So about 20 years ago, the United Nations put together something called the Millennium Village Project, and what they were intending to do was to go into these 20 sub-Saharan African villages and change them around and raise them up out of poverty, et cetera. And they did all the usual stuff, which is digging wells and latrines and crops. But after a few years, they came to organized ophthalmology and said there's so many blind people that has to be addressed as well. And so over the last 2 decades, there's been a whole bunch of this starting to go on. And the UN Millennium Village Project actually consulted with the Moran Eye Center, which is one of the leading centers in North America for this. And so they became involved in doing this, and they did economic impacts using the folks at the United Nations. So it was a fairly big thing. And again, these are the things they found. It leads to a lot of poverty, including individual, family, and community. A lot of it's treatable or preventable. Vitamin A capsules, and there's a measure of quality adjusted life year, which is what are things worth in dollars. And vitamin A capsules that prevent blindness in children are $2. And we can now do this type of cataract surgery out there for $20, $25 of disposable cost. And then you can do other things. The ivermectin for the river blindness has been huge. And if you could dose everyone with azithromycin, you could get rid of trachoma in many of these areas. I'm going to give you a very quick summary of some eye anatomy. I'm going to show you a video about how you can cure a blind person in about 6 minutes in the third world. So looking at this diagram real briefly, this is your eye cut in half. The retina's back here. This is where the nerve goes to your brain. The lens of your eye sits right behind your pupil, and when that turns cloudy, that's a cataract. And if it clouds enough, you don't see very well, and when it gets really bad, it's real bad. So there's a schematic of what happens. Lens turns cloudy, and it scatters the light, and it blurs it. And these are the types of cataracts that we see in the third world, and these are, light perception cataracts. This eye can tell you if it's night or day, and that's it. There's no other functional vision. So you get somebody with cataracts like this in both eyes, and they can't do anything. And we can take these cataracts out through a manual technique, and that's a cataract that's been extracted from that eye that was quite brown. And then for visual rehabilitation, we put a little miniature artificial lens in the eye, and that makes a huge difference in terms of their ability to see. So I'm going to try to run this video. It ran last time, so bear with me here. Let me see, and it's not going to do it this time, so I'll tell you I got it elsewhere, because this is a very short video, and I think it'll bring home the things that are possible out there. And I know Dr. Sippy and I have done these surgeries. There are certainly people out there that are experts at them. Oh, don't tell me that's not going to show. It's playing on my screen. Yeah, let me try that. Yep, let's try something here. Sorry about that. It's on my screen. Tell you what, I'll just go back to the slideshow and we will see if it'll play in there. Sorry about that. The best laid plans, okay. Shoot, this was playing again just last time I did it. All right, well, I'll skip over that. The brief answer is that you make an incision on the white of the eye, you make a groove into the eye, you open up the cataract, which is encased in a little thin membrane. This white lens will get shelled out, and you could see a brown one on the previous slide. So they come in brown and black and white. It depends on the colors. And then after that's shelled out, that little bag that it was in is still intact, and we place these little artificial lenses inside the eye. And the people that are very skilled at this, and I'm not kidding when I say this, do it in 4 to 7 minutes. And so you can set up the right kind of a camp with the right kind of efficiencies, and you can have surgeons doing 40 to 60 a day per surgeon. You get 2 or 3 of those guys together, and in a week you can do 500 to 700 cases and something like that. So it's very impressive. Another cause of blindness is glaucoma. I'm not going to spend much time on that because there's many different varieties of it. Unfortunately, as I mentioned, really not treatable. But it takes a healthy-looking optic nerve like this in the back of your eye, and through high pressure for chronic periods of time, that nerve is almost fully damaged. And when it does get fully damaged, basically you do go blind. And it's, again, very challenging. All chronic diseases in the third world right now are challenging, and the surgical treatments we have are very difficult and time-consuming. And again, at this point in time, our resources are best used doing cataract work because we can get the biggest bang for our buck. We can cure a lot of blind people in a short period of time with cataract surgery. Trachoma would be it'd be really great if this went the way of river blindness. So again, you get these chronic infections on the eyelids, and it's the pictures you see with the kids and the flies all over their eyes, and they're just spreading it around. And you got to get infected multiple times. It's not a single infection. But eventually there's such chronic inflammation on the inside of the lids, they scar and those lashes roll in. And that's where the real trouble starts, because then it causes corneal blindness. So just basic sanitation, but if you could dose everybody in every village in the region once a year with a single pill that they're giving away for free, in 2 to 4 years you'd have this essentially eliminated. But there aren't the public health systems in so many of these places to even accomplish something like that. So these people go blind needlessly. And again, people are willing to give it away. And they've now determined once a year dosing. If you get everybody, you got to get the reservoir is the problem. And this is where it comes from, and this is what you see. And you know, when you see these pictures, you say to yourself, well, just why don't they brush the flies away? Well, I've been there, and these are like no flies you and I have ever met. Because you go and you brush your hand across your face, and they lift off for about 4 nanoseconds, and then they're right back. So you would do nothing else in your whole day just other than keeping the flies off. And so this is how this gets spread around. And the final consequence is this chronic scarring on the cornea. So you can see both of his corneas have scarred opaque. And this cannot be fixed in the developing world. So once you're here, it's too late. So this is a public health issue. Here's some of those other causes, the corneal trauma, you know, that's just safety measures, the onchocerciasis, which is the success story. Childhood blindness comes in various forms, but it includes nutritional deficiencies. And then emerging is some of the diseases of either aging or excess. In Central America, it's surprising the levels of diabetes are astronomical. So we're starting to see those kinds of diseases show up there. And here's just to give you some examples of what's out there. We were in South Sudan, and we'd go into the village after work. Everything out there has got a sharp edge on it. So this was the toy they made, but there's nails sticking out, and these kids are racing around with this stuff, and it's not rare that, you know, as your mother told you, somebody gets poked in the eye. These are the kinds of bushes they have out there with these 4-inch, spines, and these people have to walk around at night sometimes, and so, you know, they'll walk around in the dark and bam, they get poked in the eye, that kind of stuff. So it's not rare that that stuff happens. So what can be done about this? Well, so there are some answers out there, and addressing cataract problem is the first thing that's on the menu because it's more than half of the blindness and it's very addressable. There are millions that need surgery, and high-tech, what we do here is really not going to be the answer. It's not going to work in the developing world. So in the long term, it's teaching the local docs, but that's a 10 to 20-year process if things go well. It's just a long story. But there are examples out there of systems that can go in and deliver high volumes of these surgeries at a high quality for very reasonable costs. And there are examples in both India and Nepal about this. And they are starting to expand that work around the globe, and that's some of what we're doing. And then you've got the public health initiatives that we talked about. So Moran Eye Center has been involved in this at a pretty high level, and again, these are the usual nice and lofty goals. But working with an organization called Himalayan Cataract Project that I'm going to talk about right now, these things are fairly reachable. So I want to talk about Nepal. So 20-some years ago, Nepal was not only, it was a developing country, but it was a backwater in terms of eye care. So they estimate in 1994, there may have been 15,000 cataract surgeries done. And if you don't put that little lens in the eye that I showed you, the outcome is dramatically worse. If you don't have a lens in your eye, then you got to wear Coke bottle glasses. So really, in the third world, in any world, even in our world, nobody tolerates that anymore. So until you get to not only doing higher volumes of surgery, but you incorporate that lens, that's been a huge difference. And as of 2010, they were doing that many surgeries, and they all had implants. And these are high-quality surgeries. Nepal right now is the only developing country in the world where rates of blindness are falling. And it's due to these two people I'm going to introduce you to. So this is a Nepalese surgeon named Sandak Ruit, and he was trained in a few different countries, including Australia, but had a strong desire to go back and help and work with his people. And when he started doing this, there was no infrastructure in Nepal. And he met an American doc named Jeff Tabin. And Jeff was climbing Everest when he was young and was going to go into orthopedic surgery. And after he saw all the blind people in Nepal, he changed and went into ophthalmology. So he and Sandak Ruit teamed up and formed Himalayan Cataract Project. And together, after several years, they built a very modern eye center in Nepal called the Tuganga Eye Center. And this eye center, I don't know the exact numbers, but they're at this center alone, they're probably doing 50 to 75,000 surgeries a year. And then they do these outreach camps all around the country. So they're doing, again, over 200,000 of these. So these little lenses that we put in the eyes, in the United States, you got to pay $100, $130 for one of these. That's what the facility pays when we put it in your eye. They develop their own intraocular lens laboratory and are making very similar quality lenses for $5 to $10. So that's all part and parcel of how you get the cost per case down to $20, $25. And so they now sell 500,000 of these lenses a year, and they only use about half of those themselves. They're now selling them to other developing countries. That's how well they're known they become. And this has really become a major success story. And one of the techniques they develop for these high-volume surgeries is they have a 10-foot table, and every right eye lays down on this end of the table, and every left eye lays down on this end. And this guy never moves. These guys are Iron Men, and they'll sit and operate all day, and he personally can do over 100 a day. And they can do them every 4 to 6 minutes, and he never moves. That one patient lays down, they operate. As that patient sits up, the next block patient is laying down on the other side. He sterilizes his gloves, moves his microscope over, and he operates. And so these people can do an amazing number of cases and high quality, very good outcomes, in fact, compared to US standards. And then they send camps out across the countryside about 10 times a year, and they go to these regional centers, and they'll set up their operating rooms situation, and they train local staff as well. And in the early days, this was kind of what it looked like when he first started doing this. Literally, they go to these villages, and nowadays they have some decent facilities, but they let it be known in the region that the eye doctors are coming, the cataract camp is coming, and they'll do, depending on the number of days and the number of surgeons, 500 to 1,000 in 3 to 5 days. But these were some of their original conditions they worked in, and they just had, it was really quite primitive initially. And this is what it looks like on post-op day at one of these camps. These people are all going to have their patches taken off, and they're all going to be happy because they get vision back right away. So on the morning after surgery, this is the scenery that you get out in the courtyards and such. And again, they're spreading this out into the countryside. And there's also, they can make this a self-sustaining system. So it turns out no matter what country you're in the world, there are people that can pay for things. So the modern version of cataract surgery, where we take it out through small incisions and use a little slicker technique, there are people in every society that can afford to pay for that. And they set up these models where every paying patient can fund 2 unpaid surgeries at the lower tech level. So it no longer is necessarily dependent on charity or ongoing donations. You can actually make these things self-funding, and they can pay for themselves. And they are all over India and Nepal right now. So I'm going to take a short break here to answer any questions, and I'm going to give a real quick show and tell of some of the things and why we like to do it. But this would be a good time if anyone has any questions.
Do people come back and get their second eye done?
So the question is, do people get second eyes? And the answer is it depends on how many show up for their first eyes. So we never let anyone go away without one eye done. And so everybody gets a first eye done, and then later in the week when we're there, if the volume of first eyes has been taken care of, then we start doing second eyes. And that varies. We often get to second eyes, but we just got back from Tanzania about 3 weeks ago, and we were swamped. We got only to first eyes on that trip.
I can't remember the context, Roger, but you mentioned that it takes 10 to 20 years to train local doctors. Why does it take 10?
It's not just 10 to 20 years to train the doctors to get the whole system operating, but Dr. Sippy and I, after college, did 4 years of med school, 4 years of eye training, and 1-year fellowship and 2-year fellowship. So once you're out of a college level, you're still looking at, and you can abbreviate that some, but the surgical training to do these cases is not easy. So if you said today we're going to take fresh medical students and turn them into eye doctors, that's 5 to 7 years minimum. Then they need some experience and seasoning. And then you've got to get you've got to get the public health system or the government to get them a building and get them the microscope they need. And so it's an entire thing that has to be built up. And you can get the doctors trained, but if they don't have the support staff and the equipment, they're not going anywhere. You can put a building up. If you don't have trained doctors, you're not going anywhere. So you're kind of herding cats at the initial outset, and you don't know where you're going to get to what's going to get to the finish line first. But we did this in Ghana over the last 15 years, and now they have their own independent eye center. They're training their own docs. And when we go, we don't go do the big numbers of cases. We now go and they're operating, and we're assisting, and we're elevating their skill level. But that was about a 15-year process for all of that to come together to the level that you can call it self-sustaining in a regional center of excellence. But 5 to 7 is optimistic, and that's if you're working with trained medical students already. So and then there's just lots of hurdles to things moving fast in the developing world. You know, you think something's going to happen, and it's 2 years later and nothing's happened. So it's more frustrating than you would like it to be. So you have to have a long view. It's a 5 to 10 year process minimum. And that's, you know, in some places we go, there are trained doctors, ophthalmologists, but they're going to take 3 years of additional training to get up to speed because their training just isn't up to snuff either. So that's if you've got someone who's already graduated from an ophthalmology training program. So just, there's a lot of variables.
Has a, excuse me, an occlusive goggle or some kind of protective eyewear ever been used to try to protect from the swarming flies?
You know, again, having been there on the ground, these are people that are looking at today's dinner as their biggest challenge. It just, they got other things going on, and this doesn't even hit the radar because, you know, those pictures were taken in South Sudan when we were there, and those people are, you know, 10 meals away from starvation. It's a horrible place, and they've just got so many other challenges that are day to day that sounds good, but, you know, you can do some local hygiene things. You can try to keep people farther from the livestock. Problem is that that's their #1 commodity. If you don't keep your livestock close, it's going to be stolen. So your livestock lives in the village with you, and you light dung fires every night to keep the bugs off of them because that's your most valuable possession. So it's, you know, like I said, they're facing more immediate concerns on a day-to-day basis. So so Africa's where I've done most of my work. So in America, there's 1 eye doctor, 1 eye surgeon for every 20,000 people. In Africa, it's probably about 1 in a million. So they've got a dramatic shortage of people. And this is the classic thing you see. And this guy, if you look, both of his pupils are white. So he's totally blind. These people are always undernourished because they're dependent on somebody else to feed them and house them. They're kind of hunched over in their own little world. They're not interacting with you. You can kind of see it happening. But it's not just adults. I mean, it's not rare that we see kids with cataracts. We don't really know what causes them. Probably something genetic, probably something. But this is not rare either. And this is a kid that is probably not going to live more than a few years in the developing world. And here's another classic example, those white, bilateral white pupils. So this guy for who knows how many years has been just dependent on the care of his family, and he can't do anything. Sits in the hut all day, doesn't do anything. Here's a woman whose other eye was already blind, and this was her only seeing eye. And you can see we've dilated her getting ready for surgery, and her cataract's totally white and opaque. So these are people that are completely non-functional. And this is what you get when you do take the cataracts out. So the day after surgeries, you see them and you start taking the patches off. And this is what happens. They just, in 30 seconds, you just watch them transform. And first they don't quite get it. They kind of are like, what? And sometimes, especially in some places like South Sudan, some of these people have never seen a white person. So the patch comes off, and the first thing they see is your face staring at them. And so they take a little bit, but this is why we do it. And you just get these, and this was a situation where we could do both eyes. So, but this is why we go. Any other questions? Thank you for inviting me. Appreciate it.
Thank you very much.
Okay. All right. Thank you, everybody, for kind of suffering the change in guard here midstream. So the reason, I gave this lecture for this class about 2 years ago, and Roger was kind enough to give his full lecture last year. And the videos from MCAT are on the web, and you can see Roger's full hour lecture from last year. But the video worked last year. The video worked, yeah, everything worked. Oh yeah, the video worked, so you can go back and see it. So I just kind of feel that what he's done and the organization he's worked with can almost be a compare and contrast to my experience that I've had in the organization I've worked with. And although we're all tugging on the same rope, and although we all want the same thing, it can be approached a little bit differently. So Orbis is a nonprofit that's based out of New York City, and it's been in existence for about 80 years. So it does have a relatively long track record, and this idea of building capacity, taking time, well, they've been at it for 80 years, and so they have built capacity, and they have some incredible success stories. You know, when you talk about cataract camps that Roger was talking about, there is a little bit of a taboo thing that goes along with that in my world. It sometimes is lost on people because, oh, you're doing good and you just gave that guy sight in 5 minutes and patted yourself on the back and wasn't that all great? Well, it's becoming better because we're becoming smarter and we're becoming more self-aware, but people like Orbis were the ones that made us wake up and actually start changing our paradigm. So why can a cataract camp be a problem? Can anybody give me one reason why a cataract camp, flying in a team of people, doing 1,000 cases, helping all those people, how could that be a problem?
There's no follow-up.
Okay, so one answer is there's no follow-up. How do you know you didn't give half of them infection? How do you know that they didn't lose their eye to infection 2 weeks later from a delayed bug staph epidermidis? How do you know that? Anything else? What else could that cause? How about the great white hope? Okay, what about that phenomenon, right? So I'm not going to go in and see my local doctors. I'm going to wait for the great white hope to show up, and I'm going to go in and have them take care of me because they know what they're doing and they're the leading experts, and my local providers don't know. So you undermine your trust sometimes in local providers. They're the ones on the ground every day. They're the ones there to help you when you get the stick in your eye or something happens. So that's another example. You know, and how about the idea that there's no infrastructure? You came in with all your equipment, you set it all up, and then you took it all down and took it away with you. Right? So you didn't really build any capacity there. You might have relationships. They may welcome you back next month with the new team or next year with the new team, but there's, again, no capacity left behind. So that made it kind of taboo. It became an ego game. You're going to go do 500 cataracts and pat yourself on the back and fly back to Santa Monica and go live your life and go see your other patients. But what happened back there? I mean, do you even care? That was the taboo. Of course they care. But again, they're busy. They're working a real life. They've dedicated free time. They flew on their own tab. They did all this stuff on their own. And yes, they did make a big sacrifice. But it was just for a week. Okay, so that is what inherently is the problem. But you can see as the demographics in our population are changing and we're aging, we are so far behind the curve that it is a necessary evil, as it were, perhaps. You need to do 1,000 cataracts in 3 days just to even stay ahead of the game. And it's going to take you 15 years or 20 years to build a true self-sustaining program. So Orbis is different in a way. Again, I'll give you, he's already gone through all the numbers, so I'm not really going to talk on that. I'm going to just advance it with this thing. So again, just some of the idea, but what I wanted you, he didn't say is this. Okay? The burden on women in our world is immense, and blindness is a major burden for women. They're going to be second on the list to go into town and have the great white hope take out your cataract. Okay. So these are old experiences. This is my dog and pony show from things I did a long time ago, and getting ready to get my life back here very soon, and hopefully we'll be back in the game and doing some things. But I went to China, Changsha, China. It would be about where Atlanta is in China compared to the United States geographically. So it's an inland city, and you know, horrific pollution, another disease, chronic mediator. But China was trying to create these centers of excellence. And so what they did was they built this brand new Changsha Hospital 2 right across the street from the rat-infested Changsha Hospital 1. And they just moved all the staff and all the people just into this new sci-fi, high-tech, I'm talking Star Trek type building. This building was sick, crazy, high-tech. I mean, doors opening and closing and blowing air on you to sterilize you when you want, I mean, crazy. And then just all the same little things came over where you keep your towels and, made out of like bamboo stuff. I mean, so again, they built the building, as Roger was referring to, but they didn't have any infrastructure for the people to come over. Okay, so here's Orbis. Much higher tech we're talking about. We're talking about a higher level of skills transfer. You're going to be teaching people to fish here. I'm not going there to do 300 cases. I'm going there to do about 10 cases. But the cases have been picked 2 to 3 months in advance by Orbis full-time doctors that have already gone there. The relationship was built a year ago with the Department of Ministry of Health. The media blitz has been going that Orbis is coming to train your local doctors, and congratulations, Dr. Chin got the fellowship for Orbis. His name is all over the media. He's the local provider that's going to be trained. We're going to build confidence in the local people. Then the Orbis people screen the patients to make sure they're not VIPs and the president's daughter and all the stuff that can be snuck in the back door that the Great White Hope can come help. Real people. Okay, now what am I going to go do? I'm going to go do normal surgeries, bread and butter stuff that you're going to do 80% of the time, not some exotic disease that I know about because I trained at Emory with the CDC affiliation. No. What are you going to be doing every day, and how can I make you better at what you do? Right? And so what we're going to do is I'm going to show you 5 ways to do the same surgery, and then I'm going to make you do it the same 5 ways. And I'm going to take instruments away from you, and I'm going to do things that you're not used to doing, linear thinker. Americans are very unique. For some reason, from kindergarten, we become R&D experts. We think outside the box. My experience universally, and I usually don't make blanket statements, every foreign medical grad I've worked with thinks linearly. I was taught this way by my preceptor, and this is the way you do it. Well, tissue doesn't follow any rules. I haven't seen a single person step out of a textbook. Right? So I need you to be thinking. I need you to be a thinker. So that's what I'm there to teach you. Okay? So you have to understand, though, culture. You're not in America anymore, people. You're in their home, right? You need to show them respect in their house. And if you don't understand their culture, you're going to be the stupid American stepping all over themselves, saying stuff you're not supposed to be saying, right? So this was actually a very interesting dynamic in China. So who are we dealing with? He's the boss. Next in command, third in command, okay? She was assigned to me as my fellow because he was big enough to pass it on. He actually got the award for Orbis. And he said, I know how to do all this stuff. I've been in America. I was at Duke for 5 years. I know how to do this stuff. She doesn't, though. And she's going to take my place probably in about 5 years. So why don't we train her? That's a big deal. Big deal. Okay, and then what she does, she pays it forward. She says, this is my fellow. And while we're in clinic together, since she can't do the surgeries, I'd like you to teach her also. Okay, so typically I would be talking to him. But he gave me permission through her to talk to her. Okay, I would be showing him disrespect if I was not giving him that hierarchy to give me permission to do this, right? Okay, so again, you need to understand your audience. I deal with the extremes of life and what I do. I see a bunch of old people and a bunch of little bitty people. And in between, I give them to my partners. So we're looking at little kids. We're looking at, older people. So this clinic here. So this guy comes in with his son, and I'm going to examine him. They've got their number. They've been pre-screened by the Orbis people a month ago. We have to be very careful, though. These guys in China, man, are the masters of duplication. And they figured out the system. And when we came out there were about 5 number 9s and about 6 number 10s. And we were like, oh, man, really? So we really had to vet out who had a real badge and who actually had just forged a badge. Okay, so now we pre-screen the patients. They've been pre-screened already by a doctor from Orbis a month ago. Now they're coming to the boss, quote unquote, and I'm going to say, yeah, you're the case we're looking for. So then, can we get more people in here? So this is all, medical students and fellows. This is my friend, the medical director of Orbis at the time, Hunter Cherwick. And again, we see some faculty members popping in, seeing how their students are doing, and we're getting everybody lined up. And again, the hierarchy, the boss standing here and his people kind of next to him. Okay, so now we're actually going to complete the documentation. I actually have paperwork. Okay, I actually have a file on this person. It wasn't somebody who just laid down and I took out their cataract and they laid down. And who was that again? Okay, I got a piece of paper. Okay, now I got a paper trail. Okay, so we're going to get everything done. We're going to write out the surgical plan. Everybody's going to agree. We're teaching them how to plan. What's our plan? We're not going to be any surprises in the operating room. Okay, then Hunter, the medical director, has to then sign off on me. He says, yep, appropriate patient, not the chairman's daughter. We got everything through here, no forged badges. Yep, you examine them. And then he's going to run it by the anesthesiologist, who's also a volunteer. He's from Houston. He's going to do the anesthesia. And so what starts happening here is this big hierarchy of training. Surgeons training surgeons, clinic training clinic, anesthesia training anesthesia, techs training techs, nurses training nurses, biomedical people training how to triage the machine that we're going to leave behind and give you your 800 number on your cell phone so that if that machine goes down, you know how to fix it. We're going to capacity build from top to bottom. It takes a lot of infrastructure. It takes 80 years of history to have these relationships. So this is post 9/11. So even in China, the airplane's sitting on the tarmac. So I've got to go through security. And the patients are in pajamas, and they got to go through security. And they're like wanding them and stuff, and I'm like, this is ridiculous. All right. But this is the coolest thing on the planet, this airplane. Now they have an MD-10. This is the old DC-10. They took it, and they gutted the whole airplane, and they turned it into this super high-tech, basically communication center. It can talk to satellites. It can do all kind of crazy stuff all over the planet without any, just electricity, basically. And they have their own generators. Pull it out, put oil in it, and go. We've got a big lecture hall. All of first class is this big lecture hall, so all the students can come, all the residents can come, all the faculty can come. They sit right there. Surgery is performed here live. They've got 27 different cameras with different gyros that they can come zoom in so nothing can get away from you. It's all being DVD'd so it can be left behind so they can review it over and over if they want. And then we've got the whole AV room going on here, but you're trapped on this airplane all day. You can't leave. You can't go walk around the tarmac. And so they bring in lunches and all this stuff, and then we all get sick from the lunches. So this is kind of a little gap. So this would be the windows of the airplane. They got a little walkway here, and this is an operating suite, real time happening in the airplane. Okay, so I'm going to preoperative counsel. She's not a doctor, she's a nurse. But I'm showing how I would want to talk to the patient. How I want to talk to the patient so the patient has expectations when we get in the operating room. So they're all learning the whole way from front to back, right? Did it fall off? Oh, sorry. So all the way from, I probably don't need this, from front to back, you're teaching. So I'm letting the patient know, they're interpreting for me, giving them their understandings. I'm going to teach them how to do a block. I'm going to numb the eye up. So the anesthetist is now there and the nurse is there, and I'm showing them how I do it. And then we go to the operating room, and here's my fellow, and that's her resident. I'm showing them how to set the devices up on the microscope or on the airplane now. Okay? Now I'm operating, I'm the primary surgeon, and she's my assistant, and she's overseeing, and then there's about 20 people out in the front of the airplane watching live. I'm mic'd up, I'm telling them play by play what I'm doing and why, and they got a translator up there, and they can ask me questions real time on the fly, and it's all being recorded. And right when you step off after doing about 10 hours of surgery, they stick a camera in your face and say, hey man, how was all that? And this is for our media stuff. Okay, techs teaching techs. How do you load the suture? How do you stay sterile? How do you kind of deal with all these things? Again, top to bottom. Okay, I showed her how to block. This is how I block in the pre-op area. Let's go ahead and block your patient here. Let's show you how I do that and why I do it that way. Okay, that's the key. Why I do it that way, not just because somebody showed you to do it that way. Right? That way, if the tissue's not normal, you can at least get out of the problem. Okay, so here you go. I'm showing you that little microscope. This little device here. They had I told you that brand new hospital, right? They had a $40,000 device sitting in a drawer. And I said, where's your viewing system? And they said, well, it's over in that drawer. And I said, well, what's it doing in the drawer? And they said, well, we don't know how to use it. They built you the hospital, bought you all this equipment, you don't know how to use it. They're afraid of it. So I said, okay, get the damn thing out of the drawer. Let me show you how to put it together. It's going to change your whole world. So she does this surgery. Now we're back at her hospital. I'm the assistant. She looks through that thing and she's like, are you kidding me? This has been sitting in a drawer for like 2 years. And I'm like, yeah. Okay, but very interesting. So now we show her the technique, right? Well, Peter's heard this story. So as soon as that surgery was over, somebody walked in and pulled her out of that room. And I'm like, what's going on? I mean, where's she going? We have another case to do. She can't know how to do something that the chairman doesn't know how to do. So she got pulled away for a 15-minute debrief on what just happened, what did you see through that, and you don't talk to anybody until you bring me back in here and show me how to do this. You have to understand what's happening culturally. So we had to take a time out, wait for her to come back 15 minutes later, ask her if she's okay. I'm fine. Let's do another case. Okay, and then we ended with a nice closing seminar. We have the whole department, everybody dresses up, and again, Orbis prepared me. Now, I had already done some stuff in Los Angeles, and I understood some things about Chinese culture and so forth, but Orbis prepared me. Brian, you're not just going to show up. We planned this whole thing for up to a year. So I got my packet 3 months in advance. I've got some cultural awareness stuff that you can watch online. So I brought a gift for the chairman from Montana. And he was already waiting for a gift for me. And I could have been that dude that walked up there and said, thank you for my nice gift, and not had any idea. And when I handed him a gift, you should have seen the look on his face. He's like, what? You knew to bring a gift all the way from America in your carry-on bag? And it would just changed everything, right? So again, cultural awareness, knowing where you're playing. You're in their sandbox, not yours. And then a nice, beautiful celebration luncheon with all the faculty and some of the team, right? So it can be brilliant. Okay, and it is really about the team, right? Orbis is an international, it's non-denominational, it's not really about religion. And so, you know, what's she doing? She's actually getting her MPH. She's going to be with Orbis for a year, flying around with this hospital, and she's writing her thesis on getting her master's in public health, right? She's not a doctor. So again, this is a team effort, right? And she was a communication whiz. Every time the satellite went down, she'd go back there and help them get it all up and running again. She was cool. We brought a medical student from Stanford with us. He was on some kind of, I don't know, medical school they do in Stanford, but he had like a month off, so he came with us. But again, so this is, you know, so we've got somebody, right, we've got somebody from the UK, we've got a guy from Jamaica, she's from New Zealand, this guy was from Peru, I think Australia, and if I remember right, I can't remember exactly where she's from. But again, international team. So even your experience there, every meal you have, every beer you have, you know, you're hanging out with very cool people, and their whole, you know, you're just learning a ton. So it's really eye-opening. Tom Johnson was my counterpart. They usually take 2 specialties at a time, so I was the retina guy. He's a plastic surgeon. So he was fixing eyelids, kids that got dog bites or congenital malformations, or even he was even doing cleft palates and stuff. He was a very talented guy. So then I get to meet Tom. I knew of him. He's senior to me. He's kind of a famous guy down in Baskin Palmer, so I got to hang with him for a week. This again, my friend Orbis. So that baby just had surgery by Tom, and that's Mom on the airplane. And then you got to enjoy things, right? You got to go actually see things. So this is my taxi ride to the place we were all meeting for dinner. So kind of cool little outdoor cafe, great food sitting outside. And then the guy came out to see the Americans, and we were all like, whoa, all right, know your cook, I guess, before you get too committed to things. Okay, so that's China. Then I had the opportunity, and this is a love-hate story, right? I mean, terrible things right in Syria right now. It's disastrous. So, but I was there in 2008, and this was Orbis's 4th trip, right? Bang, bang, 2 years in a row. 2 years in a row. Okay, when Bush was in office, Syria was on the axis of evil list. You as an American cannot go. You say that one more time. You can't go. Okay? Unless you're going to give up your passport and go in illegally, and then you're never getting out. So how do I go? I go through Orbis, and they have a relationship. They got my visa for me in about 10 days. And I walked in there like I owned the place. So I use Orbis, selfishly, to get me places I can't go very easily as an American. That's what I get out of it. but it's relationship building. Consistency, consistency, we're not going to go away, we're the real deal. Okay, so this is the team, 2 weeks. 1 week was one team, 1 week's another team. So look at this. We got people from San Diego, we got people from Ecuador, little bitty Missoula, Montana's representing, we got Singapore, right? It's brilliant. Great team. So this is my Ecuadorian counterpart. She was also a fantastic plastic surgeon and a pediatric surgeon, but she was doing a lot of plastics at that time for these kids. So she straightens out crooked eyes, stuff like that. You know, if a kid's eye stays crooked for too long, the brain just learns to ignore that eye. We call it a lazy eye or an amblyopic eye. It's not called lazy because it's turned in. It's called lazy because the brain doesn't listen to it. So again, so she's working with kids and I was working with older people. So here's my fellow. So she's a Syrian. And then he was an Egyptian, her mentor. Again, he kind of passed the love down. Said, I don't need it. I'm a full professor. She's an uprising star. Let's give her the Orbis Fellowship. Media blitz. Her name's on the newspaper. Her face is on billboards. Orbis is coming. You have a local fellow that's going to get trained and get a certificate and going to be, you know, a star when Orbis leaves. Local confidence. Okay, again, knowing what you're dealing with, though. So this lady's the patient, and I'm trained in the U.S. You're my patient. I'm going to talk to you. I don't care who's in the room with you. I don't care if you're 5 years old or 95 years old. If you're the patient, I'm talking to you. Well, she wasn't very happy about that. She was not very happy that I looked her in the face. She wasn't happy that I even talked to her. And I was like, yeah, you know, you walked in. I mean, you're by yourself. And so she just sat down. She didn't say anything to me. So we went and got her husband. And he just was intimidated. He didn't know the protocol, and he didn't want to mess anything up for her, so he just kind of sat in the waiting room. So we get an interpreter, and he comes in, and then suddenly, now she's happy. We're talking to him. You know, that doesn't make any sense to me. Makes perfect sense to her. It's her choice. So we talk to him about how to do her drops and what's going to expect and what's it going to be like on the table when he's not in there and she can't understand the language and stuff like that. So we get everything worked out. And then they mic me up and they, okay, what's going on here? What's that called? Yeah, right? Can't wear that in the operating room. It's not sterile. She comes walking in. I'm like, you got to get out of the operating room. You can't wear that in here. And the first thing they thought, you can't wear that in here. Religious thing. No, an operating room. You can't bring your street clothes in. Put whatever you want on. It's got to be sterile. So they're like, oh, let me see what he's saying. Okay, so they go fumble through all this stuff and they find some stuff that's been cleaned at the medical laundry. She puts it back on. She's back in the operating room. Of course you're welcome. Just follow the rules. All right. So then here's the Ministry of Health. This is the front of the airplane. Okay, they're watching me on a big 6-foot plasma screen doing surgery with their fellow, and they're asking questions and answering questions, and we're going from there. So now again, got to be very clear on communication. This gentleman had a situation where he had a bubble in his eye, and it was very important for him to position his head a certain way to float the bubble where I wanted it. Well, he was a little machismo, and he didn't want to take any orders from her. Right? And she's the doctor. She's actually a doctor. So I got to go in the room, and I got to talk to him directly, and then she's translating for me, making sure that he's understanding actually what I'm saying, and he's going to do what we need him to do. So again, it can be complex, you know. You just got to have open eyes and open ears and be flexible. And so in between cases, while we were cleaning the operating room and cleaning the instruments, I would run out to the front of the airplane, and then I would just give a lecture. Give a quick little 10-minute lecture and answer questions and brainstorm with them. That's all being filmed. It's all staying behind on a DVD. So we can boo or hiss or cheer. I know this is the president of Syria still. So he's an ophthalmologist. I don't know if you knew that. So he didn't want anything to do with what he's doing now. I don't know if things have changed, I'm sure. But his dad was the king. And just like the Kennedys, his older brother was being groomed to be king. So he knew he wasn't going to be king. He was just going to be prince. So he goes to Cambridge, goes to medical school, and he's in his residency for ophthalmology. So Dad gets leukemia So they make older brother king, and then older brother gets killed in the car. So guess what? You're king. So he didn't really want anything to do with all this mess that he's got, but I think now that he's lived in that role for so long, he is who he is. But he came in and he actually played with some of our toys, and he was a super nice guy when I met him, but who knows? Maybe he's a puppet, maybe he's the man, who knows? But it's kind of weird, right? You got a Harley Davidson store right there in Syria with his picture above it. But you got to go out and enjoy the culture and the food, right? You got to eat the food, you got to talk to the people, talk to young people. What do you think about Americans? What do you think about Canadians? What do you think about, Europeans? Tell me what you think. I'm privileged to be in your country. I'm an American, and you're on the axis of evil list. Okay, I was very close to Iraq. Some of these places we're hearing about, right? So what's the saddest of sad things, right? I mean, all these heritage centers and all these destructions has gone on there. And all these people took us into their home. We had tea with them. Just beautiful people. And this is Palmyra, right? We just took it back, or somebody just took it back, whatever that means. All this stuff was blown up. It's just crime. So my heart's sad. That thing's about the size of 2 Volkswagens, by the way. So this is what, since the first flight, Orbis is 80 years old, but the airplane came online in 1982. So since the flight, so the Orbis is huge. Orbis has on-the-ground programs all over that have nothing to do with this razzle-dazzle airplane. They've got local programs all over. But this is what the airplane alone has done in the last 30 years. The number of people impacted, the number of people trained, right? And they just keep coming back, and they just keep coming back. And that's the relationship building. But again, I want to show you long-term country programs. They have over 200 running all the time. Flying Eye Hospitals, a lot of razzle-dazzle. That's kind of fun. Gives them a lot of media coverage and so forth. Gives them a lot of press. But this is really where it's hitting the road. And again, it's this training from top to bottom that's most important. And it's going to be sustainable. So I think that really what this comes down to is, where am I in the global impact and the creation of sustainability, and where's Roger? I went to Moran Eye Center too. I'm an alumni. I'm probably going to be involved in their program. They just got a $55 million angel grant from a donor, and they're going to expand their program. But how do you emulate this capacity building the right way? Okay, P.S., back to your question. So Orbis, I do the surgeries. The fellows do the surgeries. You have a little more infrastructure. Orbis people go back the next week, and the next month, and at 3 months, and they see every patient, and they fill out more paperwork, and they know the infection rate, and they know the outcome rate, and they actually have these numbers to stand on, and that leverage gives them clout for the next place they're trying to go, right? So somewhere we've got to help all these blind people that are depressed and isolated and dying of malnutrition. And someplace we need to build capacity from ground, from biomedical technicians, nursing, all the way up to potentially the team leader, if a physician is the team leader anymore. So I wanted to have this fusion lecture because I think that is actually a very important compare and contrast. Where are we? What's the ultimate place? Can we think long-term and generational and keep pulling on that rope, knowing that's the way to go ultimately? But right now I've got this need, and how do I fill this need and do it ethically and do it culturally sensitive? So that's why I wanted to have us together. I thought separating this by years, each different audience just gets a different flavor, but I thought it'd be important to see the two. So that's it for me. So if you have any questions, I'm happy to. Yes, ma'am.
How is Orbis funded?
Orbis is a nonprofit, and they are funded, so United Airlines donates coach seats to all the physicians traveling. So United Airlines donates seats to get the physicians there and home. FedEx does all of the maintenance of the airplane for free, so all the annuals and the things that need to be done to keep it up to specs. And FedEx and United, and I'm leaving one major player out, donate almost all the pilots. And so a lot of these guys are retired, but to keep your certification to fly this MD-10 around, I mean, right, you have to be doing a medical every 6 months. You have to show your proficiency. It costs money. So if these guys are even retired, they're given their time already. You can't expect them to pay for all that stuff. So their companies are covering it for them.
But not the flying hospital, the whole.
Oh, well, again, it's been around 80 years. It's just a nonprofit. Individual donations, you go online, it'll say donate $5, you know, and then they have people, you know, Gates Foundation, there's other people that they've, of course, approached. And so you could, you know, they're nonprofit, you could see all their list of donors and stuff. But some people are heavies, you know, giving them tens of millions, and some people are giving them $5. And they just live like everybody else.
No USAID, no government.
Not that I'm aware of. Other than, you know, let's say that, you know, if they get the Ministry of Health on board, maybe they'll pay for the media campaign locally. That kind of thing, right? And then they take, you know, some of those people I was showing you are docs. They're eye docs, but they're just 1 year out of training. And they don't want to just go to work in their country, maybe. They want to go see the world a little bit. So they kind of sign up as what we call them, you know, Orbis Fellows. And so they commit to 1 or 2 years to be that infrastructure person who's flying ahead to get ready, flying back to check on things. So they're flying all over the place, and, you know, they're by themselves a lot of times because, so it's a little sketch out there sometimes, but, yeah. Peter? Go ahead.
Any idea of why 2/3 of the blind people are women?
Well, it's just that, you know, I mean, if you've been to any of these lectures, I mean, this is the burden of, you know, socioeconomic poverty, right? I mean, women take the brunt of everything all the time. And so this just becomes who's nourished, who's malnourished, who gets care first, who's in the pecking order. And so that's just what it comes down to, unfortunately. Yes, sir.
Have you been able to, excuse me, have you been able to be assured that there's a multiplier effect, that the people you're teaching to fish are teaching others to fish? And
Well, again, that's the idea, and that's this consistency, that's this, you know, back and forth and calling, and how's the program going? Do you need anything? You know, should we come back in 2 years? Are you up and running? You know, does one of your graduates want to join us for a year? And then, you know, that kind of thing. And so I think that that's how they've just been so successful. You know, the relationships they have with these governments are mind-blowing. I came into this all through a sad story, a little bit back door. I wasn't supposed to go to China. I'm too young, right? To do retina, to be a faculty member for Orbis for retina, you're supposed to be 10 years out of your fellowship. Okay, so I was 3 years out of my fellowship, okay, but arguably came out of maybe the top fellowship in the world at the time. You know, it just happened to be the way it was. And the director of Orbis's medical program, Hunter, trained a year under me. So what happened? They had this program all set up a year in advance. Everything was all lined up, and they got a phone call from their retina doctor in New York saying, I just got diagnosed with leukemia, and I'm starting my chemo next week, and I'm not going to be there. So I wasn't the first on Hunter's list. He went through his black book, Orbis's black book. 80 years of experience, called every person they could find. It just happened to be the worst timing. Our big national meeting was 2 weeks away, or ophthalmology's huge national meeting, 30,000 people, was 2 weeks away. It's China. It's not like you're just going to Costa Rica. And it's retina. It's a specialty. So he broke a few rules and called his superiors and said, I got this guy Sippy that might just be nuts enough to come on short notice, and he's going to hold his own. I know him. I know he can do this. He's not even going to flinch. But if I call him and he says yes, we've only got like 3 weeks to get him all of his papers and everything and get him his visa. So I went to my group the next day and told them what was happening, and they just said, go. They got me my visa for China like in 72 hours. Okay, I mean, that's unfreaking heard of, right? I mean, in my hand, like in 72 hours. I don't even know how that happened. So, and they got me all the papers. So that's how I got in. So I did Orbis a favor. So now I'm the young guy with some clout. So then I said, you're going to waive all those damn rules about me. I've already proven I can do this, and I get to get on the list. And that's how I got to go to Syria. And so I just have kind of fallen down a little bit on this. Hunter, my good friend, left. He's no longer the director. And I'm more interested in doing these ground-based programs now. I've kind of done the Blind Eye Hospital. So I'm making a major life change in about 3 months. I'm actually quitting American medicine, to give you an idea of how fed up I am with the system in this country. And I would be a hypocrite if I didn't say I try to affect change. I've been in D.C., as you heard from Peter, for the last decade. They know me by first name in the hallways. And it is a beast. And it is deliberately designed to be broken. And you don't send a kid to Montessori in 1971 and tell him to be somebody's boy when he's 50 years old. The best heart surgeon in the country gets paid the same as the worst heart surgeon in the country. It is socialized, if you believe it or not. If you don't think it is, you are blind. So, the saddest part about this is I'm standing on the shoulders of giants who trained me. I'm going to be 50 years old. The demographics in our country alone say I should be working until I'm 70. The 3 predecessors in front of me in Little Missoula, Montana, we got away from the rat race. I'm as far away from the rat race as I can be. I moved to Siberia. Okay? My 3 partners ahead of me, 55, 56, 55. I'm going to be 50. I haven't called a single contemporary and told them what I'm doing. They didn't say, I understand, and as soon as I graduate my next kid, I'm right behind you. There is going to be a massive flight in 5 years of 55-year-olds leaving, and our boomers are coming, right? 10,000 a day on Medicare for the next 19 years. It is a tsunami of entitlement. So you're going to have a bunch of C students taking care of you, unless you're lucky enough to die soon. Sad, sad state of affairs. But I'm going to go do this stuff. I'll feel good about it. Don't need a paycheck. All right. Woohoo! All right. Any other questions? Peter, you had a question maybe?
Well, I really appreciate the fact that you put both of these lectures together. I see the contrast and the comparisons. But there's a disconnect to me in terms of your work and Roger's work. Roger was saying 10 to 20 years to train somebody to do cataracts. And, the Flying Eye Hospital is going in and taking people who are not, maybe they had finished medical school, so then he was down to 5 to 7 years. And doing...
They've already finished residency. They're ophthalmologists already.
So...
I'm starting with an advanced population already.
Including the people who were really the assistants to the assistants.
Yeah, so if you don't understand the medical hierarchy terminology, so you're a medical student, and then the 1 year after medical school has its own name called internship for whatever reason. And then you go to residency, and that's when you start specializing in either kind of usually the house of medicine or the house of surgery. And then after you're an orthopedic surgeon, if you want to be a knee specialist, you're going to do a fellowship in knees. So I had a faculty member, a fellow, and a resident. So they were already surgeons, they were already ophthalmologists, so it's a little unfair. I'm taking a trained population and I'm trying to bring them up to what we considered Western standards of care. I'm trying to teach them to be thinkers a little bit. Whereas Rogers, the South Sudan story is horrific, right? So they have this guy who decides to stay instead of the intellectual flight that always happens, right? You train a doctor up and then they're like, I'm out of here, man. It's ridiculous. Okay, so they train this guy up in South Sudan. He's a resident. They get him up to speed. Tabin and these guys teach him how to do the surgery so he can chip away at a few every day and every week, and he can kind of keep rolling. they get the hospital built, they get everything, they get the equipment donated, and then they just come in and just blow it up like overnight. And then South Sudan becomes a, disaster again in warfare, and people pushed out and literally blown up. Okay, so they spent years getting to that level.
Yeah, and unfortunately, when I'm hearing your talk about Syria, I'm thinking that's happening in Syria.
Absolutely. That whole hospital, that was the first charity hospital in all of Syria built in Aleppo. Again, the model, do a private case, 2 freebies. Private case, 2 freebies off the profit you made from the private case, right? That's all gone now. So, you just got to have, you just got to be patient. I mean, this is a game of not your lifetime. This is a game of generations. I mean, you got to think like the Japanese, man. There ain't no way. And we're Americans. I mean, when we drive through McDonald's, I want to get a fix right now. We just don't think that way. And it's hard, I think, for a lot of my contemporaries and people I talk to. They're just like, man, doesn't it just drive you crazy? You go work, 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 and it's gone? Yeah, but there's 9 more that are still running. That kind of, I guess that's how you have to think about it.
Well, please join me in thanking Brian for
All right,
his
gang.